This PowerPoint presentation will cover the basics of radiation safety. So this slide is going to show you a little bit about the history of radiology and some of our other diagnostic imaging techniques. It's not anything that I feel you should be required to regurgitate on an exam, but just so you know where we've come from and where we are now. In 1895, William Röntgen discovered X-rays, and in 1901, the first radiographs of animals were taken in Vienna. And Röntgen, the guy that just discovered X-rays a couple years back, wins the Nobel Prize. In 1915, we have the first use of X-rays on animal patients in United States veterinary schools. And by 1930, most U.S. vet schools have radiographic equipment. In 1965, we have the founding of the American College of Veterinary Radiology. If you've ever heard of a veterinarian who is boarded in a particular area, that is what this refers to. So if a veterinarian is boarded in radiology, they are part of the American College of Veterinary Radiology. In 1966, ultrasound was first used to detect pregnancy in sheep. 1971, we have this first CT scan used in humans in England. And the 1980s, we have MRI introduced commercially. So that's where we've come from in the last century or so. So one of the primary things that we strive to do in radiology is to make sure that we use as little radiation as possible to get a diagnostic image. So we follow a principle called ALARA, which means as low as reasonably achievable. So we want to reduce our radiation levels to a level as low as reasonably achievable to get a diagnostic image. The human body is composed of 80% water, and radiation interaction with cells is what primarily affects the body and how we get damage. So there are concerns about additive amounts of radiation and latent effects of radiation. So doses of radiation are cumulative over a lifetime. And those doses may not cause an effect in the body right away. So we call that a latent effect, something that happens later on in life. At the levels of use and the amounts of use, even in a busy veterinary hospital, doses are very low for the technical staff. The one thing that we do worry about is our secondary or scatter radiation. That is when the primary X-ray beam hits things and bounces off. We call that secondary or scatter radiation. That bouncing off is uncontrollable. So that is really what we are looking at to protect ourselves from when we talk about radiation exposure for the veterinary technician. All of our tissues are sensitive to ionizing radiation, like X-rays, but radiation is not selective. So all of the tissues are affected. However, certain tissues can be more sensitive. And we're really looking at the interaction of X-rays and the tissues at an atomic level. So we have injury that can occur at the time of exposure, but may take time to show damage. So again, that goes back to those latent effects. So we see somatic effects, those effects from radiation that occur within the lifetime of that individual. And we see genetic effects, which are effects from radiation that occur in future generations. So what we pass on to our offspring. When we look at what can happen when radiation encounters cells, there are pretty much 4 different results. So radiation can pass through the cell with no effect. The cell could display no immediate effects, but there might be damage that could affect cell division or mitosis. Third thing we can have happen, there could be obvious cell damage, which compromises portions of DNA. And the fourth is that cell death could occur. So we've got everything from no effects to cell death, and then in the middle we have no immediate effects, but when we start to divide the cell we have problems, or we have immediate effects that damage the DNA. So the nucleus is the most sensitive target on the cell, especially during cell division, because radiation targets DNA. So while all tissues are sensitive, we do have greater sensitivity in certain circumstances. So greater sensitivity is going to occur in tissues that are younger or have higher metabolic activity or are proliferating better than elsewhere. So we look at specific types of tissues. There are also specific organs or systems that are most affected. So things like the thyroid gland, the lens of the eye, the lymphatic system, bones where the hematopoietic tissue is, reproductive system, and also fetuses or young animals, because they have germinal epithelium and they have a higher rate of metabolic activity as they're growing. And then organs like the skin or the intestinal epithelium, those have a high proliferation and growth rate of tissues, so those are also more sensitive areas to radiation. So one of the things we have to look at in terms of radiation is what's called linear energy transfer, LET. And what that is a measure at which the rate of energy is transferred from the radiation to the tissue. So we're looking at how much energy comes from the radiation and goes into the tissue. So if we have a high LET, that means that we have radiation going into the tissues and leaving a lot of energy in the tissues. And that gives us an increased risk of potential damage. If we have a low LET going into the tissues and less energy is left within there, we have a lower risk of damage to the tissues potentially. So X-rays have a low LET with higher penetrability. So that means that X-rays have a high ability to pass through the tissues, but they leave less energy there. So again, high LET, we end up with a patient who has a lot of potential damage from that energy. Low LET, like X-rays, we end up with a patient that has lower potential damage to the tissues. So the low LET from the X-rays results in less immediate effects on the tissues where the radiation has passed. But again, we have high penetrability, so the X-rays can go deep into the body or straight through the body. So when we're looking at what happens with our patient and how X-rays make us an image, we're looking at photons of X-ray going through some material, and then where that material is dense, the radiation is absorbed, but where the material is less dense, the radiation passes right through. So if you think of this bar in the middle of the screen here, as a patient, it's not particularly that dense. We have a certain amount of radiation that passes through to the other side and hits our receptive device, which is going to create our image. If that material has an increased density, that means we have less radiation passing through to our receptive device. So if, for example, our material is more dense, like bone, we absorb radiation better, less radiation hits our receptive device, and we end up with a whiter picture. So the more radiation that hits the receptive device, where our picture is, more radiation means more density on there, which means a blacker image. If we have something like bone that is more dense, less radiation passes through, less radiation hits the receptive device, makes less density on the picture, means we have a whiter image. So something like bone is going to appear white on your radiograph, and something like fat is going to appear black on your radiograph. So we can have objects that are the same thickness but composed of materials of different densities, or we can have objects that are the same material but different thicknesses, which gives them a different density. For example, the top boxes here could represent a section of bone and a section of fat, where the bone would be more dense than the fat. The bottom boxes could be a thin patient, less fat, and a thick patient with more fat. Second case has the same material but more density because there's more thickness. So in either case here, we have the more dense material requiring more X-rays to pass through them to prevent the X-ray beam, because the density prevents the X-ray beam from passing through. So we need more X-ray through the dense materials to make a picture. When we talk about how we as technicians can get exposure to radiation and how damage to tissues can occur, we have three sources of that. The first being the primary X-ray beam, so the X-ray beam shooting down from the X-ray machine into your patient. If you were to be underneath that area where the beam is hitting, that would be one way you can get exposure, so that's the primary beam. The second way is through those dashed lines that are bouncing off your patient, that's scatter or secondary radiation. Again, that's uncontrollable which direction that goes. So if we get hit by those, that is a way that we can be exposed. And the third is through X-ray machine leakage. So I've put kind of a green glow around the X-ray machine here as to make you think about X-rays leaking, but you don't obviously see them because they're invisible. So as far as the primary beam goes, we never want any part of our body to be in the path of the beam, even if we have protective equipment on. So if you've seen individuals wearing protective equipment when they're taking radiographs, that is made of a thin sheet of lead. But that protective equipment, because it's such a thin sheet of lead, only protects from about 75% of the primary beam. So if you stuck your hand underneath the primary beam with a glove on, you're still going to get 25% of the X-ray beam hitting you, even while you're wearing your protective equipment. The protective equipment only protects you entirely from scatter radiation. So when we're looking at scatter radiation, and that again is produced when the primary beam interacts with objects in its path and it bounces off, that's when we wear our proper protective equipment for protection. And the amount and direction of scatter radiation really depends on your machine settings, how much tissue you're irradiating, so kind of the field size or how much beam is coming down, and what kind of tissue it's hitting. And then lastly, we have the X-ray machine leakage, and we can really control that by making sure that our machine is calibrated regularly. So once a year or so, we have an X-ray technician come in and calibrate the machine. It's not something that typically falls to the role of a veterinary technician. We usually look for a company that specifically deals with that. And they are calibrating and making sure that there is no leakage from the X-ray machine, so that that is not one of the sources for our exposure. There are three big methods for radiation safety as far as the technician is concerned. The first is time reduction. So there are two ways that we can reduce time. The first is by avoiding retakes. So that means that we use good technique to properly take a diagnostic image the first time versus having to redo things. And the second is using the quickest exposure setting on our machine that we can in order to take a diagnostic image. So we're reducing the amount of time radiation is coming down to our patient, and we're also reducing the amount of retakes we do, so that reduces time overall. The second thing that we're going to do is increase distance from the source to the technician. So if we imagine a flashlight held on a piece of paper very close by, if we look at the light on the piece of paper that the flashlight bears, we notice that it is a pretty bright circle of light on the paper. It has a very well-defined edge. As you start to pull that piece of paper away from the flashlight, you notice that you now have a dimmer circle and the edge maybe is not as well defined. So if you think of your X-ray beam just like that beam of light, the same thing is happening. The further away you get from your beam, the less precise and less intense the radiation is. So in order to reduce our radiation exposure to scatter radiation, we're going to use distance the same way that the flashlight example showed. So the further away we get from our X-ray beam, the less exposure we have. And the way that we figure out how much exposure we've now decreased, we look at what's called the inverse square law. So the inverse square law is a really simple formula. It's 1 over x squared, where x is the distance that you've moved. So for example, if you move 2 feet away from the source, the radiation intensity is decreased to 1 over 2 squared, which is 1 over 4, or 1/4 of the original value. So you've reduced your radiation exposure by 4 times. If I move 3 times away from the source, 3 times the distance, or 3 feet, for example, I've done now 1 over 3 squared, or 1/9 of the original radiation dose, or 9 times less. So the same thing happens to your patient when you move them away. Same thing happens to you as the technician when you move away. And the reverse happens if we move closer. So if I move 2 times closer to the beam, I'm increasing my dose by 4 times, 1 over 2 squared. The last thing that we can do to reduce our exposure is to use shielding. And there are a couple of ways we can do that. In order to shield between the source and the technician, we could either wear protective apparel, which we'll talk about in a second in more detail, or we could stand behind a shield meant to block the X-rays from passing through it. So if you look in our radiology room, and in many practices, you'll see a black screen about person height that is mobile, and you stand behind that, that is made of lead. The window in it is made of leaded glass, and that lead prevents the X-ray beam from passing through, just like our protective apparel. So we would either stand behind that lead shield or wear protective apparel, or you could also stand behind, if you have a wall that is constructed with enough materials that would block the X-ray beam, so if it's a thick enough brick wall or cinder wall or cement wall, if it's just sheetrock, you're not going to get that protection because the beam will pass right through. So it has to be made of the correct materials. When we're looking at protective equipment, we always want to wear proper protective equipment that is routinely inspected, and by inspected we mean that we're not only looking at it physically, but we're radiographing it for signs of damage. So if we said that this protective equipment was made of lead, a thin sheet of lead, and I radiograph through the lead, I would expect no image on the other side. I'd expect totally white image, because no X-rays should have been able to pass through the metal. So even more dense than bone would be metal. And if it's very dense, X-ray beams are absorbed, they don't pass through, and that's what causes the image to be white. So if I'm radiographing, say, the apron here, and I don't see something totally white, maybe I see white with a black line or a black crack, then I know that my apron is compromised and there's nothing I can do to fix it. I have to throw that one away and get a brand new apron. So in terms of the pieces of equipment that are required by the government for safety, we have gloves, we have a thyroid shield covering the thyroid in your neck. When you're wearing your thyroid shield, if it is uncomfortable, it is likely on correctly. And then the last thing we have is an apron. So if you look at the apron, it covers mostly the front of you, and it covers all those important areas we talked about, the reproductive organs, the big long bones, say, of your legs that have bone marrow, and most of your intestinal epithelium is covered by that. A lot of your skin is covered by that. So that apron really protects a lot of information. The last thing that is not required but is found in some veterinary practices are goggles that are made of leaded glass to protect your eyes. Now, goggles aren't required, and the reason they're not required is because eyes are pretty small in comparison to the whole rest of your body in terms of surface area, and it's highly improbable that the scatter radiation is going to directly go into your eye versus another part of your body that might be larger. So one thing that I tend to ask the students is, what if you close your eyes? Could you protect your eye, the lens of your eye, by closing your eye? And the answer to that is no, because your skin is penetrable by X-rays, just like your lens of your eye is. So just because you close your eyes does not mean you protect your eyes from radiation. You'd need the goggles to do that. One of the most important things about our protective equipment is that we need to make sure that we store them correctly, because again, they're a very thin sheet of lead. So if you think about holding a wire and you flex that wire over and over again and bend it in the same spot over and over and over again, what eventually happens to the wire? It breaks. So same thing with this equipment. If you bend your thyroid shield over and over in the same spot, you're going to end up with a crack there, and then radiation can slip through that crack and you're no longer protected. So when we store our equipment, we either need to lie them flat or stand them upright or hang them. So gloves are either laid flat or standing upright on pegs. In our clinic, we have them on pegs. Thyroid shields typically laid flat when they're not in use. They could also be hung. Aprons tend to be hung by the shoulders when they're not in use. Now, when you get into the clinic and you look at the apron protective equipment, you're going to notice that it really only covers the front of your body. So if you turn sideways next to your X-ray machine, scatter radiation can bounce up and hit the side of your body where the gown is not protected. So when you're taking a radiograph, you really need to make sure that you're facing the X-ray beam with your apron so that the proper parts of you are protected. A couple of other things that we need to worry about in terms of safety. No pregnant women or people under the age of 18 should be in the X-ray room during an exposure, whether they have protective equipment or not. Now, this isn't to say that you cannot have a pregnant person in the room. She is able to make her decision as to whether she feels that her protective equipment is protective enough, but we try really hard not to have any pregnant women or people under the age of 18 in the room during the exposure. Again, because fetal tissue young growing tissue is more susceptible to radiation. We also want to make sure that we remove unnecessary personnel from the room. So if it only takes one technician to hold the patient and take the exposure, there shouldn't be a second one in there. And we also want to rotate personnel during the procedures. So even if you have somebody that is more adept at taking radiographs than someone else, that doesn't mean they should be the only one taking all of the radiographs for that clinic, because then they're also going to get the most potential exposure. So we want to rotate our personnel so that not just one person is getting exposed all the time. We also want to try to use non-manual restraint when possible. So non-manual restraint can include chemical restraint like sedation. It could include positioning devices like V-troughs, which is pictured in the bottom middle here, and that is the correct spelling of trough. Sandbags, tape, things like that. Some states also prohibit manual restraint by technicians. So in some states you'll find that you cannot stand in the room holding your patient. You have to use either physical restraint or chemical restraint. So the app is not working at this point because this is a recorded lecture. So I wanted to quiz you on this. Does personal protective equipment protect your body from the primary X-ray beam? True or false? The correct answer here would be false. The personal protective equipment doesn't protect you entirely from the primary beam. It protects you entirely from secondary radiation or scatter radiation. So some of the governing bodies that deal with radiation in the United States are the U.S. Nuclear Regulatory Commission, the NRC, and they declare that pregnant women should not receive an occupational exposure greater than 0.5 rem, and we're going to talk about what rem is in a little bit. So many of you have heard of the Title IX compliance that all educational institutions that receive federal funding shall not discriminate on the basis of sex. This amendment also includes protections for pregnancy. Becker falls under these laws, and thus I have to spend a few minutes talking about pregnancy and radiology with you. There are risks to the fetus if a pregnant woman is exposed to radiation. The ideal resolution would be for the woman to remain outside of the X-ray room when any radiographs are taken, so as to avoid all risk of exposure. She can still set up the equipment. She can even take the exposure if she's behind proper shielding like a lead-lined wall. Pregnant women should also be offered a fetal radiation monitoring device to monitor their exposure at the level of the abdomen. It is truly up to the pregnant woman whether she wants to declare the pregnancy, continue taking radiographs with the proper protection and monitoring, and/or refrain from taking radiographs during her pregnancy. What it means to be declared is that you have voluntarily informed your employer in writing of your pregnancy and estimated month of conception. At Becker, this declaration can be made with our medical director of the veterinary clinic. The medical director would then inform me that the individual needs a fetal monitoring device. If someone chooses not to declare pregnancy in writing, but still wishes to obtain a fetal dosimetry badge, they can do that through me verbally also. Declaration of pregnancy, whether verbal or in writing, remains confidential with both myself and/or the medical director. We will make arrangements for how to go about using the fetal monitoring device in lab as discreetly as possible. If you are pregnant or may become pregnant during the semester, you can find the documents for the NRC's recommendation, our radiation policy, and the form for written declaration of pregnancy on Canvas in a separate module in our course. The next thing we're going to begin talking about is how to control the X-ray beam to go exactly where we want it to be, because this is going to help us reduce our exposure. So what we're looking at here is how to control what is called the collimator, or you may hear it called the collimator. Either way is fine to pronounce it. What the collimator does is it controls the window or aperture through which X-rays pass to the patient. So on the image on the right, you're looking at an X-ray beam, and I've given you, a visible X-ray beam just for example's sake. So this is where the X-ray beam comes down onto the table. And on the left here, I've given you a dog where we are potentially doing a radiograph. So if we wanted to radiograph this dog's chest, I would make sure that that collimator light is on the dog's chest. So what happens with the collimator is that since X-rays are invisible, the collimator projects light, visible light, just like a light bulb, onto our patient so that we can see where the X-ray beam is going to hit. So on this dog, I've represented this little orange kind of square here for you. a rectangle that represents where the X-ray beam is going to hit. And you'll notice that it also has an X through the middle of it. That allows you to see where the center point is, which sometimes can help us with positioning. So in terms of collimating, if I collimate more, or I increase my collimation, that makes my window smaller, which makes the X-ray beam tighter to the anatomy of interest. So on the left here, we're showing you collimating more, closing that window, and making, on the dog below, that X-ray beam window smaller. On the right, you are seeing collimating less, so that means we're expanding the window, expanding the area that's exposed to the beam. And you'll notice on the dog below, we've made that rectangle bigger. So collimating less or decreasing collimation means that we're opening the window to allow more X-ray beam out. So why do we want to have good collimation? Well, there is really one big reason why we do this, and that is so that we can limit scattered radiation. So we know that most of our exposure as technicians comes from scatter radiation, so we want to limit as much scatter radiation as possible, and we do that through collimation. So there are two things that you should see on a radiograph if you've collimated well. What I've given you on this slide is, if you look at the outer gray line, it's kind of a soft rectangle, that's your radiographic image. And on the inside there, we're looking at some bone, okay? You know bone looks white, so I've made the outside of the bone white. The inside of the bone would be probably white or dark gray, but that's neither here nor there. So what we see with good collimation is around the image, so around that bone, we have an unexposed border. So remember when we talked about density, bones being dense, if the beam didn't pass through them, you ended up with no exposure on your image, so that ended up being a white area. So with collimation, we want this white unexposed border all the way around the image. If you were looking at physical film in your hand versus a digital image, so if you're looking at physical film, it actually looks clear. If you are looking at a digital image, you are going to see white. The second thing we want, besides an unexposed border all the way around the image, is that the black background is as close to the anatomy of interest as possible. So you see that the black rectangle I put around this bone is very tightly close to that bone. All right, so good collimation reduces scatter radiation. And what you'd see on the radiograph is an unexposed border all the way around the image, and that the background of the image is as close to the anatomy of interest as possible. So here's another question for you. The primary reason for using a collimator is to, and your answer should be reduce scatter radiation. So some of the tips for radiation safety: if we had a portable X-ray machine, we want to make sure that we are not hand holding it. The reason being, if there's any X-ray machine leakage, we stick our hands right next to that. We've just exposed our hands. And then also, if you have this portable machine, you want to make sure that you are not pointing the X-ray beam at other people or rooms that are adjacent to where you are, where there are people in there. So really pay attention with the portable X-ray machine on how you're holding it, which shouldn't be by your hands. We have devices to do that. Or that we're not directing it towards other people. We also want to make sure we're calibrating our machine regularly. Remember that it's going to limit our machine leakage. And we also want to make sure that we're using the correct receptive device system. So we're going to talk about receptive device systems as the semester progresses. We want to make sure that we use the right receptive device that gives us the best diagnostic radiographs. And this is also going to help decrease our time setting. And remember that reducing time is going to reduce scatter radiation. So you also want to plan your procedures carefully to avoid retakes, again reducing time. And we also want to make sure that we keep an exposure log that identifies who we took radiographs of, what exposures we took, and who were the technicians involved. And also we need to follow any state and federal radiation safety codes. As far as radiation monitoring devices, there are 4 common types of them. And what they're doing are detecting radiation exposure for the technician. We wear them during every radiographic procedure, and they register a charge over time if they're exposed to radiation. and they maintain that charge until we return them to a detection lab for reporting. So the most common method of radiation detection for personnel are film badges. They contain a small piece of film in a little light-proof envelope. When the film badge goes back to the laboratory, they take out the little piece of film and they decide how black it is, and the degree of blackness correlates with a dose value. The thermoluminescent dosimeter, the second one pictured here, contains either lithium fluoride or calcium fluoride crystals that store energy that's produced by radiation exposure. So the X-ray beam hits the thermoluminescent dosimeter, energy is emitted as light, and we're now again looking at the exposure, which correlates with a dose value. What's nice about thermoluminescent dosimeters is that you can wear them for a longer period of time before they get evaluated. The third type is an optically stimulated luminescence badge. This is what we have at our clinic. There is aluminum oxide inside that illuminates in proportion to how much radiation is received. So radiation hits the badge, aluminum oxide lights up. And what's nice about the optically stimulated luminescence badge is that they're extremely sensitive, so it allows low dose exposure to be recorded. The last one pictured here is called an ion chamber, and that is an electrometer that's used, there's an electrometer that's used to charge the chamber before you wear it. And then as the chamber is exposed to radiation, it discharges some of the charge. And so at the end, when we send it into the lab, we look at how much charge is left, and that's proportional to the dose that you received. So those are 4 different methods that we can use to detect our radiation exposure as personnel. So some rules for dosimetry badge use. You do not want to take it home. It should always stay at the practice where you are using it. It should be stored away from possible radiation exposure, so you don't want to leave it sitting on the X-ray table to get exposed to more X-rays, because then that's going to artificially change what you got as a technician exposure. You want to store it away from heat and sunlight. Heat and sunlight and high temperature and humidity are going to make that film or the ion chamber or whatever's in there can make it discharge a little bit and look like you have more exposure. You, again, only want to wear it at the registered site and only when you're using radiation equipment. It doesn't need to be worn around the whole practice. It just needs to be worn when you're taking a radiograph. When we wear our dosimetry badges, they need to be on the outside of our protective equipment. So typically we wear them attached to our thyroid shields outside of the apron. Again, it needs to be outside of the equipment, so that picks up the most amount of radiation you could possibly have had, and then we hope that your protective equipment protects from some of that. You also do not want to share your dosimetry badge with anyone else, so you should have your own with your name on it that is respective to you. If you go to a practice where they have visitor badges, you should be the only one using that visitor badge, and then at the end of your use, it should get turned into the lab and somebody else will get a different visitor badge. So we're going to look at radiation doses, and we send these badges in and we're looking at, okay, what are the results we get back and what do they mean? So the first term that we're going to talk about is called the Roentgen. So you remember back to my history of X-rays that we had William Roentgen discovering X-rays, right? So a Roentgen, or big R, is the quantity of radiation exposure delivered to a particular point. So we determine that by measuring the ionization of the X-ray beam in air. So you are not air. This does not apply directly to you as a technician. The next term is called a RAD, or radiation absorbed dose. So this is the dose of radiation that's absorbed by an absorbing material, which could be a body. RAD does not equal the amount of X-ray exposure, only the amount absorbed. If you look at RAD, we have international units of grays, and then we have non-international units of rads. So 1 gray is 100 rads, so that's just something to keep in mind, depending on which way your lab reports that information. The last one here is a REM, or a Roentgen equivalent man. So this is what now takes into account humans and types of radiation. So the Roentgen equivalent takes into account the quality of the radiation, and doses from different types of radiation can be compared. So we take the RAD, the dose absorbed by an absorbent material, and multiply it by what we call a quality factor. So the quality factor for X-rays is really easily, it's 1. So what you see between rad and rem, rad is any particular absorbent material, and a rem is what is absorbed by humans. So rem is what we look at when we look at our dose reports and how much exposure we got as people. So the rem unit, international unit, is called a sievert, and then the non-international unit is called a rem. So 1 sievert is 100 rem. So you should remember 1 gray is 100 rad, 1 sievert is 100 rem. And then rem is the one that you're going to see reported in your dose reports from the lab. When you look at your dose reports, you're going to notice that you're not getting rem reported back to you. You're actually going to be getting probably millirem. So millirem, 1,000 times less than a rem. So if you're looking at whole numbers in millirem, you may think that you have a really large dose, but remember it's millirem and not rem. Just in case you were interested, quality factors for other types of radiation. Alpha radiation is 20, neutrons 10. Those are a couple of different ones for you. So X-rays or gamma rays, we have a quality factor of 1. So we want to know what's the maximum dose of radiation that a person can receive in a given period of time. And this is something that is set by the National Council on Radiation Protection and Measurements under the recommendations of the International Commission on Radiological Protection. So for a lifetime exposure, we have the formula of 5 times n minus 18 rem, where n is your age. And remember that we want nobody under the age of 18. So we start with 18 as n. So your legal maximum exposure for your lifetime, however old you are, is 5 times n minus 18 rem. This turns out to be about 5 rem a year for occupational exposure. So if you're working with radiation, it's 5 rem a year. If you're not working with radiation, the commission or the council here recommends only 0.1 to 0.5 rem per year. Non-occupational exposure also includes fetuses. The fetus recommendation is 0, or considered in some places non-occupational exposure up to 0.5, but again, we try to keep it at 0 for fetuses. So 5 times n minus 18 is a formula you will want to remember, and occupational exposure being no more than 5 rem a year. So again, if you're reading your dosimetry report coming back from the lab and you see a number of 5, you need to look at the units and see that that's millirem, so you're nowhere near a 5 rem maximum. What is the name of the device we wear in radiology lab to detect our radiation exposure? Is it a dose meter, a lead gown, a dosimetry badge, or an ion chamber? So in our lab, we're wearing dosimetry badges. When we're taking exposures, we mentioned that we need to maintain records. So you're going to find a radiology logbook in the lab. At a minimum, the things that we need to include in this book for each exposure is the date, the technician taking the exposure, patient and client information, so the name of the patient and the client, the radiographic position or views, and the exposure factor. So those are the settings on our machine. So for every time we do an exposure, we need to make sure that we're writing a line with all this information. And that also includes any time you take a retake. So if you have a retake exposure, that is another brand new line with all this information in your logbook. So every time you expose the machine, you have to write an entry in the logbook. This also will help us later on in determining if, say, a patient's coming in for repeat radiographs. We'll have the settings we used on them before, so we should be able to decide if that was a good picture or not. The other thing that will help with is whether you're rotating your technician. So if you see the same technician initials all the time, we need to be rotating that person out. And then lastly, it's going to help in terms of your machine maintenance. How much are you actually using your machine? And do we need to start replacing parts after a certain amount of time? So it helps with maintenance as well.